Respected judges and friends, welcome to the post-lunch session. I'll be presenting a very small series on a very important problem on outcomes of IZHV in acute intraoperative aqueous misdirection. The study was a retrospective institutional review board approved study where we looked at the EMR and interviewed cataract surgeons to find patients who had acute intraoperative aqueous misdirection characterized by acute shallowing of the anterior chamber with iris prolapse, inability to inject viscoelastic, forward movement of the lens, intraocular lens, or the bag in presence of a normal fundal glow, and after external factors were ruled out, which underwent IZHV and followed for at least 1 month period. We noted the diagnosis, the ocular findings on the slit lamp and fundus examination, the visual fields, biometry, the surgical plan, and reviewed the surgical video wherever it was possible, along with interviewing the faculty on the course of the events. And special attention was paid to the step at which shallowing happened and the countermeasures taken by the surgeon. On follow-up, special attention was paid to the anterior chamber depth centrally and peripherally. The external factors which were ruled out, some of these will be there right when you begin the surgery, but the ones highlighted can occur anytime during the surgery. So the speculum was checked and loosened if tight. Patient was spoken with and made sure that the patient is not coughing or sneezing or not holding the breath, is not straining with a full bladder. Fundus glow was examined to rule out suprachoroidal hemorrhage and choroidal detachment. And then an IZHV was performed as required. Looking at the baseline characteristics, 4 of these 7 surgeries were combined cataract and trabeculectomy, and 3 were phacoemulsification. 5 of these patients had angle closure disease. The patient with pseudoexfoliation had a coexisting occludable angle. 5 of these patients had raised intraocular pressure, and they were on multiple medications ranging from 0 to 5. The axial length was pretty much within normal range, except 2 patients, one of whom had a shortish eye of 20.65 millimeters and another a high myope. The lens, though not being extraordinarily thick, was on the thicker side. This is one of the examples of such a patient when one began the surgery normally, but during irrigation aspiration, I realized that the posterior capsule is coming up so much that it's bulging beyond the rhexis margin, and it was becoming difficult to do aspirate the cortex with safety. Attempts to fill the eye with viscoelastic did not result in any improvement. The speculum was loosened, patient was not coughing, straining, or breathing heavily, and any attempts to deepen the anterior chamber only pushed viscoelastic out of the eye. This was suggestive in presence of a normal fundus glow of acute intraoperative aqueous misdirection. So upon checking the tension also of the globe, which was very hard posteriorly, the diagnosis was confirmed. And when nothing else could happen, I proceeded with a IZHV. A 26 gauge Alcon vitrector on the Infinity machine was used to create an iridectomy first, then to eat capsule or zonules whichever lie in the periphery, till the point of time when there was a sudden shallowing of the anterior chamber, and everything then became easy. You will see the reverse pupillary snap sign right now, and I will just show that sign again, which basically represents the point of time when the anterior hyaloid face has ruptured. And thereafter, the surgery was performed with complete ease. You see the anterior chamber seems to be well formed, and there is no more problem. I just want to highlight the settings of vitrectomy while performing IZHV. This I have not seen being documented anywhere. This is derived, not completely written, copied from the Alcon manual. So the basic principle is, while doing iridectomy, you be in IA cut mode, use the lowest possible cut rate so that you have control on the shape and size of the iridectomy. This iridectomy should be performed ideally at a site where there is no incision, so that a laser, if required in the post-operative period, can be performed easily. The next two steps are performed with the cut IA mode with highest cut rate. So on follow-up, we realized that all of them actually, that the aqueous misdirection happened at a stage when the AC had actually shallowed. And on follow-up, all of these had normal intraocular pressure, some of them on multiple medications. Only one patient required additional laser procedure for a recurrence, and the post-op regimen that was given to them, practically the most important aspect was using atropine and tropicamide phenylephrine combination, both carefully being tapered stepwise over a period of 2 to 4 weeks each. These were the steps that we followed. The confusion in naming is also reflected in the confusion in management of this situation. The latest review article mentions that pars plana decompression should be performed either with a needle or through the pars plana approach. But this is very similar to the Chandler's procedure, which is decades old. We anterior segment surgeons and glaucoma surgeons have to take control in our hand and get the capability of performing a safe and effective IZHV through the anterior chamber. The limitation is that is it small series for a rare thing, suboptimal visual acuity we cannot explain, and lot of medications were required. Angle closure glaucoma and raised intraocular pressure seem to be risk factors. The strengths of the study are that this is the first series on IZHV through anterior route in acute intraoperative aqueous misdirection. This has been published for chronic aqueous misdirection, but not for acute setting, and none of the patient record showing the efficacy of the procedure. Thank you so much.
First thing is how safe it is, because this looks very unsafe compared to you. You are from an institute where retina VR surgery is easily available. Why did you not go through the pars plana and went through the anterior route?
Actually, this is
because this looks very unsafe.
That's what I wanted to say, that this is not unsafe. I have been doing this. I have seen people do this for many years now, but it was not getting documented earlier. And a lot of surgeons do this for chronic aqueous misdirection. So if you see the 7 patients done over a period of 3 years, none of them had any complications because of the procedure.
And did you confirm all of them did not have any choroidal hemorrhage or choroidal detachment?
Yes. So the immediate resolution of the anterior chamber depth and intraocular pressure and a fundus examination that is routinely performed.
So did you do post-operative ultrasound for these patients to confirm that they were not the case of vitreous hemorrhage, a choroidal hemorrhage? Did you rule that out?
B-scan was upon resolution with an IZHV is an indirect proof of aqueous misdirection.
No, but you could have confirmed it that this is not choroidal hemorrhage. That's a confirmatory, na? Confirmatory will be done only by ultrasound.
But even a dilated fundus exam could have been
so
good
that
enough. So you would have done it in a way.
Yeah, that we routinely do for every patient first post-op.